Hello everyone, you're watching sqadia.com, and now we are on the management and differential of osteoarthritis. In this, we'll be going through its clinical features specific to hip and knee, because these are the most common form of osteoarthritis. The patient presents with hip and knee osteoarthritis, and then we'll be going through the treatment of osteoarthritis. Now, the clinical features include the symptoms and the signs. What would we see if a patient comes to us with osteoarthritis of the knee? The most common is the pain. This core pain is especially common in the night pain. The patient is unable to sleep properly. There is joint stiffness. Patient says that he or she is unable to move properly. There is fatigue. There is sleep disturbances, mostly due to the pain at night. And as it's a chronic process, the patient may be depressed. There's reduced functional ability and to carry out the daily activities of the daily living. Now, what are the signs? Usually generalized, so certain signs could be specific to certain joint. But generalized, it's the tenderness is there. There's bony swelling. There is a reduced range of movement with pain at the end range, usually, especially at the end of the flexion extension. There is increased pain. There may be a crepitus on the movement. There could be clicking sound when the joint is moved in extension and flexion. There could be weakness and wasting of muscles acting on the joint. The signs of inflammation, deformity, and instability in severe cases. So the most common feature is the pain. Pain experiences vary hugely both over time between individuals and according to the joints affected. Anxiety and depression both affect the perception of pain and its response to its intervention. Coming to the joint stiffness, a gelling resulting in the people having difficulty getting moving from the rest. Patient usually complains it is unable to get up from sitting position. Particularly common in the early morning after first awakening. Swollen joints are very common. Wasting and weakness of the surrounding muscles. Palpation may reveal bony swelling at the margin of the joint. Signs of mild inflammation such as heat over the joint line and infusion may be present. Infusion may be due to increased production of synovial fluids by the synovicites. There is a reduced range of movement. Why? Because there is actually fibrosis of the ligaments around it, with the pain at the end of the range, and crepitus may be felt as the joint is moved. Why there is a crepitus? Sometimes the osteophyte gets so large they get dislodged into the joint as a foreign body. So when the bones are moving, they rub against these osteophytes, resulting in a clicking sound called as this crepitus. In advanced diseases, there may be inability may be detected. Other clinical features which are specific to hip joint, which may be involve pain usually felt in the groin, laterally over the hip, and radiates down the anterior lateral aspect of the thigh of the knee. Walking distance is reduced. Patient may present at rest, and at night pain can be particularly troublesome for the patients. What actually happens is, to reduce that debilitation due to pain, patient starts to move less and less. So there is definitely a problem that patient says that I cannot get up properly, I cannot go to the washroom, I cannot tie my laces, I cannot bend down properly because I am having pain in my hip. Complex movements which involve deep flexion combined with rotation are often difficult or impossible to perform. Coming to the specific clinical features of the hip joint, then on examination, usually there's antalgic gait characterized by an uneven cadence in which the less time is spent in the stance phase of the painful limb. A reduced range of movement with internal rotation is often restricted early in the disease progression. Now there are two tests called as FADIR, then there is a FABER. FADER is flexion, adduction, and internal rotation of the hip. That is gets affected early. Now the FABER, once the disease process becomes globalized throughout the joint, it gets involved whole of the joint. then both the fetter and fiber are positive, that there is a flexion, abduction, external rotation is also painful. Now coming to the specific features of osteoarthritis related to the knee, they occur most commonly in the medial tibiofemoral joint, and the most common area is anterior medial compartment of the medial tibiofemoral joint. Isolated patellofemoral osteoarthritis is also common, but usually when it is there, it presents as anterior knee pain. It's initially very difficult to differentiate whether it's isolated patellofemoral or it's involving the tibiofemoral compartment as well. As we know that knee is actually two joints. There's joint between tibia and femur, there's a tibiofemoral joint, and then there's a patella and femur, there's a patellofemoral joint. And that is probably due to altered biomechanics of extensor mechanism. Usually osteoarthritis around the knee is tricompartmental, that it involves the medial patellofemoral joint, medial tibiofemoral and lateral tibiofemoral joint. In isolated patellofemoral osteoarthritis, pain is felt anteriorly over the knee and is often worse when ascending or descending stairs as the patella is compressed against the femur. Normally, when a patient if any person is ascending stairs, actually the force acting on its quads are 3 times its body weight. And if the patient is descending stairs, the pain is more worse because the force acting on the quads is actually 5 times its body weight. So it's increased biomechanical stress during descending. So if there is isolated patellofemoral osteoarthritis, there will be pain on ascending, but the pain would be further increased during the descent of the stairs. Rest pain and night pain may develop in the later stages of the disease. Special features on examination include gradual deformity of the knee, in particular the varus deformity, although valgus deformity is sometimes present as well. Fixed flexion deformity sometimes can be seen. Knees cannot lock in full extension, thus patient cannot stand comfortably for prolonged periods due to muscle fatigue. Loss of flexion beyond 90 degrees makes standing from sitting very difficult. There is antalgic gait, wasting of quads, joint effusion, joint deformity, crepitus palpable, and sometimes audible as well on movement. So what are the investigations? The first investigation of choice is always the X-rays. If a patient comes and complains of knee pain, the first thing is to get an AP lateral view of the joint as well as the bones. Although routine investigations do not help, for example, if osteoarthritis, you get a CP and ESR and CRP, they usually within the normal range. ESR may be raised, but actually it's not really significant. Blood tests are generally normal. ESR CP may be raised, but they could be raised in thousands of other things. So they are not actually more specific. Plain radiographs is simply an historical record of prosthetic joint changes. If there are X-rays available, for example, what happened for 1 month ago, or what was the X-ray is 6 months ago, and if you can compare that X-ray with the, let's say, a day or 2 days old X-ray, that is actually the ideal. You can appreciate how the joint space has been reduced over time, what is the status of osteophyte formation, how much situation has actually got worse over the period of time. But at times it's not possible to even use MRI or scintigraphy to detect pathophysiology in routine care. For example, if usually there is an antecedent cause, then sometimes this may be helpful, but not always you go for MRI straight away in a patient. So mainly it's not the investigation, but osteoarthritis is mainly a clinical diagnosis. Thank you very much. Keep watching sqadia.com.